because if you have loss of podocytes, tell me a disease where there is podocytopenia. This is an interactive class now. Disease with podocytopenia. FSGS. Okay. So the parietal, you have loss of podocyte. Parietal cells will attempt repair, but they have an insufficient repair activity. Give me a disease where I have epithelial cells proliferation or podocyte proliferation. Collapsing glomerulopathy. The theory behind that is either there are differentiated podocytes that re-enter the cell cycle, or they die as they die in FSGS, but in that case there is an exuberant repair activity for parietal cells. And these are the two leading theories. So podocytes are octopus-shaped cells, form of a cell body, primary processes, and processes. They cover the basement membrane. And endothelial cells, always a cell body with a nucleus sitting on top of the mesangium, and they have a fenestrated endothelium. Okay? Is it good? Is it clear enough? Now, when we talk about glomerular diseases, we have diseases with normal cellularity. Name one. Mima change disease. Name another one. Membranous nephropathy. It is a disease with increased proliferation and inflammation or not? No. Okay. And then when we have diseases with increased proliferation, inflammation, and the proliferation can occur in the bowel space or can occur in the endocapillary compartment. Endocapillary compartment is everything that is inside the glomerular membrane. So it can be proliferation of mesangial cells. Give me one disease. IgA nephropathy. Or can be proliferation of all the cells of the inside the basement membrane. Florid proliferation with lobulation of the glomerular tuft. One example is membranoproliferative glomerulonephritis. Proliferation in the bowel space can occur because you have proliferation of podocytes. That's collapsing glomerulopathy. Or you have proliferation of parietal epithelial cells and mixed with inflammation and fibrin, and we call that crescent, right? Now, we have diseases that are non-immune complex mediated. We have diseases that are immune complex mediated, antibody mediated, or complement mediated. So let's start with the antibody. So if the immunofluorescence for diseases that are not immune complex mediated would be negative. Okay, so you exclude, if you have negative immunofluorescence, you exclude already a big chunk of diseases. Now let's talk about diseases with that are antibody mediated. Which are those? Antibody mediated. Anti-GBM and no, membranous is immune complex. Anti-GBM and ANCA. Somebody said ANCA. So if I have an ANCA mediated disease, how the glomerulus will look like by a light microscopy? How do I call that disease? Which is, I call it ANCA mediated presentic necrotizing glomerulonephritis. The name should make sense to you. The name of the disease should make sense to you. Because it's telling you that you should see crescents and necrosis, and the disease is caused by ANCA. And then you should know everything else about that. So, this is an antibody-mediated disease. How would be my immunofluorescence? For the purpose of this course, yes.
It's the podocytes?
Yeah.
Okay.
However, in reality, in crescents, you find parietal cells, fibroblasts, inflammatory cells, and podocytes. So that's your immunofluorescence. So let's do it from here. Okay. So here I have one capillary only now, okay? And I have my mesangial cell, my endothelial cell with the penetrated endothelium, this is what it will look like. So those are Sandra deposit. Okay. Let's say our prototype is IgA nephropathy. Now we need another one. Now we have a very chubby mesangium, and we have two glomerular basement membrane. We have numerous mesangial cells. We have very large deposit. Oh, let's do the endothelial cells. Very swollen endothelial cells, and maybe there's no fenestration anymore. For the side. Now, in this case, I will have very large subendothelial deposit as being part of double contour. Those are comma-shaped deposits. The comma-shaped deposits are subendothelial deposits. They're between the original glomerular basement membrane and the endothelium. And generally this is associated with mesangial deposits as well. Okay? So I call this comma shape and PGM. Think about proliferative glomerulonephritis. You can see that in PGM. You can see that in lupus nephritis with proliferation. However, if I have here a big hump, what do I think about? Post-infectious. And for post-infectious, as well as other disease, but let's say post-infectious, I want to see a neutrophil. Okay? That is what I will show you.
What determines whether it's subendothelial or epithelial? Is it size conflict?
Yes. For example, IgM and IgA are bigger molecules and to be more endo. IgG sub-epi, but you can have IgG sub-endo as well. If we forget any, we have IgA, we have granular, we have linear, we have comma shape, and with the hump. I think we have them all. Okay, this is your immunofluorescence pattern.
What is the wire loop? What's that referring to?
The wire loop.
That's that?
That's that.
Okay.
Yeah. It's comma shape. Yeah. Okay. Now let's do a couple of cases. Yeah.
Quick question. For post-infectious glomerulonephritis, is that just the humps and the neutrophils, or is it also
The
comma
deposits.
shape?
No, you have the deposit in the mesangium.
Okay.
I have to say in post-infectious, you rarely see this degree of double contours. It's much less, but you do see some subendothelial deposits. They're not as big generally, okay? But deciding whether it was big enough or whatever. It's the hump that makes people infectious. They want you to answer MPGN that will show you double